Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman. I'll be talking today about mesalazine and ulcerative colitis, improving the outcome. الصوت واضح? Okay. So just a little hint. I'm talking now about a drug that was developed. The parent compound sulfasalazine was developed in 1938 and 1939, and it was discovered to be effective in colitis in 1941. So when I'm talking about aminosalicylates in 2021, this means that this group of medications stood the test of time and is very effective in ulcerative colitis. So the goal of therapy in ulcerative colitis is relieving the symptoms of the patient combined with mucosal healing. Optimal management relies on understanding and tailoring evidence-based interventions by clinicians in partnership with the patients. Mesalazine is the standard therapy for induction and maintenance of remission in mild to moderate ulcerative colitis. And even in severe ulcerative colitis, you can even use it combined with steroids and immunomodulators. So I'll be talking in this presentation about the keys to success of mesalazine therapy in treating ulcerative colitis. And the key points are: you should always identify your target at all times, which is mucosal healing. You should always use the optimal dose for induction therapy, the optimal dose for maintenance therapy. You should identify early enough and manage the flares while on maintenance therapy. And you should always involve your patient in the management, because compliance of the patient is the key to the success of therapy. So I'll be posing some questions and answering them with the available data. And the first question is, what should be the therapeutic goal or target of therapy for ulcerative colitis? And does aminosalicylates, does mesalazine achieve this target? The therapeutic goal, as I mentioned, is complete mucosal healing. This predicts clinical remission. It reduces the risk of hospitalizations, surgeries, and colorectal cancer in these patients. It means longer remissions and fewer relapses, and ultimately, this will improve the quality of life. 5 aminosalicylates have a proven efficacy for mucosal healing, and these are the data. Complete mucosal healing, which means a Mayo endoscopic subscore of 0, is associated with a 3-fold reduced risk of relapse compared with incomplete mucosal healing, which is a Mayo endoscopic score of 1. Mucosal healing is a strong predictor of improved outcomes. It means 66% fewer surgeries, 84% increased remissions, 42% fewer hospitalizations. A normal colonoscopy is associated with a significantly reduced risk of colorectal cancer. Normal colonoscopy means a 62% reduction in risk of colorectal cancer. Reduced disease activity on endoscopic activity index is associated with significant improvement in the quality of life in these patients. And finally, the most important piece of information is that 5 aminosalicylates cause a mucosal healing rate of 44%, a range of 35 to 62%. So aminosalicylates are very effective in inducing mucosal healing, which is the target in treating ulcerative colitis. What is the evidence for dose optimization in induction of a remission in ulcerative colitis? High doses of aminosalicylates more than 3 grams are more effective than the standard dose of 2 to 3 grams per day, and combined oral and rectal therapy is even more effective than using high-dose aminosalicylate monotherapy. And this, using the high-dose aminosalicylate, more than 3 grams, or the combined oral and rectal, will cause higher rates of clinical remission and mucosal healing, faster symptom relief, improved quality of life, and even the high doses are well tolerated. So this is a meta-analysis of 48 induction randomized control trials, including 8,020 patients, and it shows that combined oral and rectal 5-aminosalicylate and high-dose 5-aminosalicylate causes the highest induction of remission. Both interventions were superior to a 5-aminosalicylate 2 to 3 grams per day for likelihood to induce remission. Both interventions were more likely than 5-aminosalicylates 2 to 3 grams per day to induce endoscopic remission, and high-dose 5-aminosalicylate more than 3 grams a day was better tolerated than placebo. 63% lower discontinuation rate. So if you are going to treat with mesalazine, you choose the high dose, 3 grams or more per day to induce a remission, and use combined oral and rectal mesalazine. Are there other benefits of dose optimization? Yes, there are. If you can control ulcerative colitis with mesalazine, you will avoid or delay the use of systemic steroids, immunosuppressants, and biologics with their expensive cost and side effects. So you reduce and save the costs. And of course, you have more treatment options as a backup if mesalazine fails. This is a real-world experience from France, reported that in the first year of treatment, 33% of patients did not receive the optimal high dose of aminosalicylate treatment, and 45% had to use steroids to control the disease, 20% immunosuppressants, and 18% anti-TNF. High dose 5-aminosalicylates is also effective in those patients who failed on a lower dose of aminosalicylate. So, for example, if a patient fails treatment with a 2 to 3 gram per day aminosalicylate and you increase the dose to more than 4 grams, you expect that 66% of patients will achieve clinical improvement and 44% clinical remission, and 61% can achieve clinical and endoscopic remission. So escalating the dose of aminosalicylates in those patients who did not receive the proper dose achieves a good remission. What is the evidence for dose optimization in maintenance of remission? We talked about induction of remission, and the minimum dose for induction is 3 grams per day. What about maintenance of remission? The evidence is that for maintenance of remission, you should use a dose of more than 2 grams per day. This will lead to a longer remission, a lower relapse rate, and reduced level of fecal calprotectin, which reflects a good control of activity of disease. The data show from the randomized controlled trials that combined oral and rectal 5-aminosalicylates and high-dose 5-aminosalicylate more than 3 grams per day were ranked highest for maintenance of remission, and higher doses of 5-aminosalicylates more than 2 grams a day were superior to doses less than 2 grams per day in the likelihood to maintain remission. Significantly more patients on 5 aminosalicylates more than 4 grams a day maintained fecal calprotectin levels less than 50 than those on less than 3 grams per day. So the message is, for maintenance, never use a dose less than 2 grams per day. And the higher the dose, the more likelihood that you will maintain the remission and maintain low fecal calprotectin levels. Why is it important to identify flares early? Now, we talked about induction of remission, and we said that never use a dose less than 3 grams. We talked about maintenance of remission and never use a dose less than 2 grams. Now we are talking about flares during maintenance therapy. And it's very important to identify flares because patients may have no symptoms, but when you do an endoscopy, you will find active inflammation. So the potential benefits for early recognition or diagnosis of flares is to avoid serious disease complications, reduce the risk of hospitalization, reduce the risk of colorectal cancer, and of course, it is quite cost effective because you save the patient the expenses of admission to ER or to hospital and clinic visits. So patients, just to give you an idea about the prevalence of activity in patients with clinical remission, patients in clinical remission can have endoscopic disease. 45% of those in clinical remission had a Mayo endoscopic subscore more than 0, and 13% had a Mayo endoscopy subscore more than 1. The importance of identifying hidden flare is that patients who are in a flare, who have an activity, and are in clinical remission run a risk of 6 to 10% to undergo colectomy within 10 years because of the hidden activity that will flare at one time and will not be controlled. Mucosal healing associated with a significantly reduced risk of future colectomy, and CR rates are 66% times higher in ulcerative colitis patients, and strong evidence that chronic inflammation leads to chronic colonic dysplasia. And so, again, it's very important to identify hidden flares. Rapid treatment can reduce ER emergency room visits and hospitalizations in these patients. How do we identify the flares early in the course of the maintenance therapy or the hidden flares? Fecal calprotectin levels can predict relapse before the symptoms. It can reflect the status of mucosal healing. So monitoring of fecal calprotectin level can improve the prognosis by early intervention in those patients with high fecal calprotectin levels, and can decrease the need for endoscopy as a monitoring technique for activity of disease. So fecal calprotectin is an independent predictive risk factor of clinical relapse. There is a 14-fold increase in relapse risk with a fecal calprotectin more than 150. The time to relapse is significantly longer in patients with a fecal calprotectin less than 200. And fecal calprotectin is better than CRP, hemoglobin, ESR, serum albumin at predicting mucosal healing. Relapse rate is significantly lower in patients with 5-aminosalicylate dose escalation than no dose escalation at fecal calprotectin levels more than 300. So the way to diagnose flares early in these patients on maintenance therapy is to monitor the fecal calprotectin level every 3 months. الصوت مش واضح. So do the guidelines support dose optimization? Yes, they do. They support to treat to complete mucosal healing. They support high dose induction and or dose optimization to achieve remission. They support high dose for maintenance, and they support the use of fecal calprotectin in the monitoring of patients who are on maintenance therapy to detect flares early, even before the patient gets clinical symptoms. So treat to mucosal healing or normal mucosa is broadly recommended by most guidelines. The guidelines provide scope to dose optimize for induction of remission. 5-aminosalicylate dose more than 3 grams per day is recommended for induction in patients with mild to moderate active ulcerative colitis with any extension beyond the rectum. The guidelines support the use of aminosalicylates for maintenance of remission at doses 2 grams or more per day. And the 5-aminosalicylate maintenance should be continued long-term. This may reduce the risk of colorectal cancer. Fecal calprotectin assessment provides a sensitive and accurate measure of gut inflammation for monitoring patients. So what are the key messages in this presentation? Treat to induce complete mucosal healing. Please use the optimal 5-aminosalicylate dose for inducing a remission, and this dose is 3 or more grams per day. Use the optimal dose of 5-aminosalicylate for maintaining a remission, and this should be 2 grams or more per day. Detect flares early in the patients, and remember that the flares may be there without clinical symptoms. And the way to detect these flares early is to use fecal calprotectin measurement to detect these flares. And don't forget that the patient is one of the most important factors in the success of therapy. Without patient compliance, you cannot have successful therapy. Thank you very much.
Many thanks, professors. Any questions? Fadl.
Thank you, Professor Ayman. What about the use of babar gamma mesalamine compound in treatment of IBD?
The use of?
The babar gamma mesalamine drug. Babar gamma. Babar gamma mesalamine. The babar gamma mesalamine structure. Babar gamma is a drug used in diabetes. It's antifibrotic, insulin sensitizer, but we can combine with mesalamine.
I did not read any papers, and I do not have any information about its use with mesalamine in
mesalamine with babar gamma.
I do not have any data on that. Do you have any data on the use?
Okay. في trial على use of babar gamma receptor agonist and mesalamine in treatment of IBD بيقول ان هو بيمنع الفايبروزس ليه انتي انفلاماتري وانتي فايبروتيك افكت. فبيكون في الاندكشن اوف ريميشن والمينتنس اوف ريميشن بيكون معاه very high especially in ulcerative colitis. Thank you.
Okay. أي سؤال؟ اتفضل.
شكرا يا دكتور ايمن المحاضره الجميله دي. في العيانين اللي عندهم ulcerative bronchitis localized to the rectum, can I use suppositories only
Es war ein falscher Link.
مع oral?
A very good question, and I'll be in my next presentation. I'll be talking about ulcerative bronchitis, but I'll give you the answer now. Yes, we can use mesalamine, and this is the standard of care. Is to start with mesalazine suppositories first, and if the patient does not respond, then you escalate the therapy. But first, the first step is mesalamine or mesalazine suppositories, 1 gram per day at bedtime.
Thank you.